would have a great day. But you know, it's interesting because as he talked, I thought, you know, what would it have been like to be there when the first automobile came out? And to hear all the cowboys sitting around with their horses talking about this expensive, useless, it's going to damage things, it's not going to cause any benefit, and who could ever afford one? There will only be a select few that ever get an automobile. Or the same conversations I'm sure took place at the time of laparoscopic cholecystectomy. I know for a fact that a famous surgeon from the Mayo Clinic, when laparoscopic cholecystectomy first came about, said that we would never be able to do more than one in a day, and that this would never take off. So I think it was very entertaining and very good, and I respect Dr. Vollmer very much, and I think beyond the entertainment, I think there wasn't much there for the patient. We didn't really talk much about the patient. We talked about cost, we talked about different aspects of the procedure, about would it be difficult and would we be interested and is it time consuming to learn how to do it, but really what matters is what the patient wants. Well, I've been favored by the title of our session is the fact that somebody at least agrees with me, and that's they named it Laparoscopic Pancreatic Resections Will Become the Standard of Care. So I'm going to set the stage for a minute. Fact. Whether we like it or not, there is a rational and powerful force driving the practice of surgery towards less invasive approaches. We've seen that in everything from patients that are demanding smaller incisions or less invasive things. We've seen outcomes in minimally invasive approaches to almost everything inside the abdominal cavity that have shown improvements, less blood loss, quicker recovery, and yes, the evil shorter hospital stay, which I tend to belittle a bit because I don't think the patients care about that. But wound infections. So it was nice to see the one anecdotal patient that got a hernia after a laparoscopic approach for an inappropriate removal of a cyst. But the reality is we've seen with Whipple patients and distal pancreatectomy alike, these wound morbidities can be significant, especially with a bilateral subcostal incision. I'll go to a question to set the stage, and that is there an operation really where laparoscopic approach has been evaluated and subsequently abandoned within the abdomen? Is there a reason for that? How many prospective randomized trials do we have for anything that we do in surgery today? Where are the randomized trials for removal of hepatic metastasis from colorectal disease or cholangiocarcinoma resection? They're not there. The idea is that we look out for the patient, and we have to be visionary. And yes, we may go to the moon and decide later that maybe it didn't mean and lead everybody to where we thought it might lead. But there are many times when we take these leaps and it does benefit the patient, and therefore I think it's important that we continue that. Well, I'm going to quickly just talk briefly about some of the potential advantages without repeating too much of what we've talked numerous times. And then I'd like to really focus the controversy on application in cancer, because I think for benign disease, I think the feasibility and safety, we can talk about that all we want. I'm not sure that that has to be proven every single time we turn the scope to a different area of the abdomen. Everybody has been able to prove the feasibility and safety of whatever they'd like. But you know, the real important point is, can we maintain the current oncologic standards? And then even more important than that is, can we advance them? Well, as you know, there's lots of procedures that have been tried or successfully performed laparoscopically. Clearly, the two most common are distal pancreatectomy and pancreatic duodenectomy, so I'll focus the discussion there. While it's not randomized controlled trials, there is a growing body of literature demonstrating at least the outcomes of perhaps selected patients undergoing distal pancreatectomy. And until the last few years, we really didn't have any large series, but they're coming. In terms of comparative trials, there's two large comparative trials. One was a multi-institutional retrospective review, 142 patients. We recently reported our single center experience with 100 and showed that blood loss was less and the length of hospital stay was less. Again, I'll forget about the length of hospital stay, but I think if blood loss is true, I think that alone is enough to merit at least our attention. Now again, that could be because of selection, but when matched as was in these patients. That still holds true. What about for adenocarcinoma? There's really not much out there for adenocarcinoma, but again, same setting with the multi-institutional cohort and then one single institution experience from our center for specifically adenocarcinoma. And comparing those matched to patients that underwent open resection for adenocarcinoma. And again, blood loss was a consistent finding, length of hospital stay again. Well, I've shown this earlier. The data for laparoscopic pancreatic oduodenectomy is a little bit more wimpy. There's, with series greater than 20 just being a few. But we talked about before, again, with all the known biases, at least operative time is very similar to what Dr. Vollmer reported for their last 100 at his center. The blood loss, I would argue, is probably going to become less just because that's what's been shown in everything else that's done minimally invasive. And then importantly, the complication rate is within the realm of what we see with open. Of note, again, with cancer, these series all had a significant portion of patients undergoing resection for cancer. And those surrogates that we talked about, because we don't have time, by the time we get to 5- and 10-year survivals, technology changes and we'll miss the opportunity. We cannot hold out with one technology for 10 years to prove the survival advantage. So we use these surrogates of oncologic outcomes, such as a margin-negative resection, number of lymph nodes harvested, and at least short-term survival. And those are also very comparable. Well, not published, but we just, a few months ago, we reviewed our experience with 52 patients that underwent laparoscopic pancreatic oduodenectomy just for pancreatic adenocarcinoma, and compared it to all the patients at our institution that underwent open resection for pancreatic oduodenectomy during that same time interval. Again, to see if there was a selection bias. There was no difference in age. The BMI was 27, which is exactly what they see in Boston, apparently. Operative time was the same. Even the percent of venous resection, even though we just started to do that, was similar in both groups. The blood loss was less, again, and hospital stay, which was shown again for distal pancreatectomy and pretty much any study that's been done on any major operation. Tumor size was not different. Number of lymph nodes harvested, not different. R0 section, not different. And at least short term, the cumulative probability of recurrence and the 1- and 2-year survival, again, no difference. So are the favorable outcomes of minimally invasive surgery obtained with pancreatic resections? Well, I think in terms of blood loss, absolutely. Wound morbidity, yes. Shorter hospital stay, for whatever that's worth, yes. Quicker recovery, yes, which I think the patient cares about. Morbidity and mortality, I think this is a bit of a wash. We either don't have enough data to prove one is better than the other, or it will be very similar. Survival and quality of life, we really don't have any answers for yet, and I think that's where we need to focus our attention. It's not about length of hospital stay, and it's not even about the incision. It's about the patient benefits that they care about the most. Well, did we maintain oncologic standards? Well, in terms of technique and exposure, I can tell you, having done more open than laparoscopic to date, even of the Whipples, that the technique and exposure is better. I see better. Everyone in the operating room sees better. They see everything I see. It is amazing. And there's no doubt in my mind that the dissection in the CTs that were shown on the borderline resectable, which at our institution we resect and do not favor neoadjuvant treatment unless we don't think it's resectable, the magnified view and the exposure we get allows a dissection almost like I never saw open. Lymph node retrieval is the same. It should not be different. And with the magnified view, I would argue that it might be better. The margin status is the same. Again, blood loss. I think that's an important consideration, as some centers have shown that blood loss or transfusion is a risk factor for tumor recurrence or survival. Morbidity and mortality, I think, is going to be equivalent, perhaps improved, but again, as was rightly mentioned, the real morbidity of pancreatic surgery is the leak, and so far no one's been able to show any improvement in that with laparoscopic approach. Again, survival and quality of life is where we should head. But what about the most important thing? Do we have an opportunity to take this Model A or Model T automobile and make something better with the practice that we have. Can we improve the oncologic outcomes? I mentioned reduced blood loss. If that's all we ever show, and that truly is a risk factor for recurrence, that alone would be enough in my mind. What about quicker recovery? Well, the patients don't care about the hospital stay. They don't probably even care whether it was 300 or 500 cc's of blood loss. What they want to know is, are you going to get my cancer out the best we know how as surgeons? Am I going to get better quickly so that if we ever do get chemotherapy that works better for pancreas cancer, that they can get to that treatment and tolerate it better? And then something that hasn't really been addressed yet, and that is, what about the reduced physiologic and immunologic stress? Well, there are several studies showing that the stress response of a laparotomy is different than laparoscopy. There is more stress in terms of things we can measure. We all know that by the fluid sequestration the fluid sequestration after a lap versus open, I think, is very different. The patients look different very immediately. There's also more of an immune suppression with laparotomy than laparoscopy. And there are several in the basic science realm and translational realm that would argue that immune modulation is important in cancer biology. And if we could reduce the amount of immunosuppression of our operation, perhaps we could make progress from an oncologic view as well. And then the quality of life. Well, we have several prospective trials going on now to compare laparoscopic versus open pancreatic duodenectomy. Accrual is fairly slow, given the numerous other studies that we try to do in these patients, but I hope within the next year or so we'll have some data to answer some of the more important questions, and what are we doing for the patients. So a better question is, why wouldn't laparoscopic approaches for pancreatic resection become the standard of care if there is potential to improve patient outcomes? In summary, laparoscopic distal pancreatectomy, I think, has been shown to be not just feasible and safe, but less blood loss, shorter hospital stay, and it is becoming a favored approach. And whether we use standard of care or not, even for cholecystectomy, whether we call it standard of care, the majority of patients have it done laparoscopically because of the benefits. I think we'll see the same with distal pancreatectomy. Pancreatic duodenectomy, still under great scrutiny, which I think it should be. It's feasible and safe, which seems like a really easy thing to say with about anything we do. And there's multiple validation studies underway. So laparoscopic pancreatic resections are feasible. Perioperative outcomes appear comparable. Surrogates evaluating the oncologic resection appear comparable. Provides some potentially very important advantages. And we have the potential to actually advance the oncologic outcomes. Not the guarantee, but the potential. So in conclusion, laparoscopic approaches to pancreatic resection will become the standard of care. Meaning, I think with time we'll all be doing most of these. I don't think it's going to be in the next couple of years. Maybe it's 10 or 15. And it may not even be purely laparoscopic, and it may not be the robot. It may be something that hasn't been thought of yet that'll be coming out in 2 years, because we know how fast technology goes. Unfortunately, randomized trials, like just about most of the things we do in surgery, are exceedingly unlikely. It is very unlikely that I could even at our institution construct a randomized trial and get accrual, because many patients come looking for this, or when given the options of a bilateral subcostal incision or a big open wound, they would take this without thinking about the potential benefits or disadvantages. Significant advantages are plausible and are still under evaluation. Equivalent outcomes will not stifle this transition. As I mentioned, even if we did randomized studies and the outcomes were equivalent, why not have 4 little and 5 little incisions as opposed to a larger incision? So you would really, in my opinion, have to prove that it's worse for minimally invasive approaches to anything to not take over. And I think we should continue, importantly, to seek, investigate, and scrutinize novel treatment approaches. We cannot continue to ride around on our horses and laugh at the Model T that drives by. We have to embrace some of these things, try them out, scrutinize them, and I am more than behind the fact that if we scrutinize it and say this is not good for patient care, we should stop. If we say that we shouldn't do it because it's hard to do, or how are we going to train, That's not the right answer, and I don't think any of us deep down feel that way. We really want what's best for the patient. So we evaluate things. If it's not better for the patient, we should dump it and look for something else. Thank you very much.